Discover the power of seeing more. Take your cardiac PET imaging to another level. Heart-C goes beyond traditional myocardial perfusion imaging to quantify coronary flow capacity, a type of perfusion data not measured by other means. Heart-C delivers easy-to-interpret coronary flow capacity maps, and it is clinically validated with more than 4,000 patients. Heart-C's reports, along with traditional perfusion data, help you detect regional and global coronary defects and categorize the severity of your patient's disease. The ability to routinely quantify myocardial blood flow is unique to PET, improves accuracy, risk stratification, and patient selection for interventions. See the potential. Discover the power of Heart-C. To learn more, please visit www.cardiogen.com. Introducing Dr. K. Lance Gould, the Martin Bucksbaum Distinguished University Chair and Professor of Cardiology and Executive Director of the Weatherhead PET Center for Preventing and Reversing Atherosclerosis. Predicting angina and mortality, subendocardial versus transmural quantitative myocardial perfusion.
Welcome to this session on predicting angina and mortality with subendocardial versus transmural quantitative myocardial perfusion. I'm Lance Gould, Professor of Medicine and Director of the Weatherhead PET Center at the University of Texas Medical School with no conflict of interest. 50 years ago, during the golden age of experimental coronary physiology, I discovered coronary flow and pharmacologic stress however, translating the concepts into the current golden age of clinical coronary physiology took until now for developing the applications and the technology. Now, 50 years later, routine clinical PET identifies and quantifies the following core issues in cardiology, core issues such as high CAD mortality risk, reduced by over 50% after revascularization versus none, as I'll show you later. Also, angina with a normal angiogram, but imaged as subendocardial ischemia, also shown later. Microvascular disease with uniform low transmural perfusion, but actually rarely with angina, as I'll also show. Severe perfusion defects, commonly with no angina, but high mortality risk that need our attention. Low subendocardial perfusion due to diffuse non-obstructive CAD is widely prevalent, but without symptoms. Stent-jailed branches causing continued angina after procedure is common now on PET, and myocardial viability using FDG and complex CAD for viability. Now, how does PET provide these answers? Well, let's start with the basics. First, we validate it. We take images at rest and stress quantitatively in microcuries per cc. Then we acquire the arterial input function either in the left atrium or the aorta. And we then have the data in either an activity curve or a single imaged arterial input that integrates the curve, and then myocardial uptake. So we get flow by dividing the myocardial uptake by the arterial input with a correction factor for flow-dependent extraction, empirically developed. And we get cc's per minute per gram or mil per minute per gram in every pixel in every view. And this shows the validation of the rubidium flow model, in this case, with microsphere flow that's quite tight. Then step 2, we take the 21 slices, that's acquired data, and for each slice, we have 64 sampling rays where we measure the maximum intensity where the statistics is best. And then we measure pixels, mil per minute per gram for each pixel for rest, stress, coronary flow, and then their combination as coronary flow capacity per pixel. And then in addition, as you see, we track the endocardial and epicardial borders on the relative tomographic images. And here we take the endocardial border at rest and project it onto stress, then allows us to see the subendocardial shell out due to reduced subendocardial perfusion. And in this case, the subendo-subepicardial ratio is 0.54, reduced by half for 22% of the ventricle. So we can quantify the subendocardial perfusion as well as pixel-based coronary flow capacity. Now in step 3, we take this large number of data sets, 1344 pixels, each with stress flow, CFR, many views. And in order to compress the data into something usable clinically, we back project onto this map where we recolor the pictures based on 5 clinical groups, red being young volunteers, orange being risk factors only with no known disease, yellow being people with coronary disease, documented but no symptoms, and green being either EKG changes or angina, but not both during diaphragmal stress, and blue being both, and then dark blue being myocardial steal, where stress flow falls below 1. Each pixel is then colored according to this map and back projected into its original position to produce these coronary flow capacity maps. Here showing a very severe LAD stenosis proximal to the first septal perforator with myocardial steal, indicating collaterals to viable myocardium, and the other arterial distributions are okay, the LAD wrapping around the apex. Now then, why coronary flow capacity? Let's look at regional pixel values on the left. This is relative uptake at rest and stress, and you see there's a moderate, not too large defect. And now we have the stress data for each pixel and the CFR. They're back projected onto the map, and the CFC map then shows a mildly reduced mean transmural flow, not severe, but reduced. But it does show a regional reduction that corresponds to this relative mild reduction. Now, why pixel values? If we take global values of stress flow and CFR that average out the good and the bad, then if we back project, we realize that we have a map that shows reasonable flows, but we've lost all the regional details. So the global measurements are not as useful and clinically quite misleading compared to the regional disease based on these activities of each pixel per regional pixel. And global CFR fails to define coronary artery disease in this example. For example, there's a very large inferior RCA defect. The other parts of the heart have very good flow. So the global average is excellent, but a global data omits or misses this severe defect. On another example, different case, the global average is reduced, but again, that global average fails to see a very large LAD defect with other parts that are relatively good. So global measurements don't really serve the clinical purpose of deciding who needs to be cath and get an intervention. Now further, why pixel CFC? Arbitrary ROIs and assumed arterial distributions averages perfusion over the different arteries and fails to provide size or severity and specific arterial distributions. So here's a common LAD circumflex right. Arbitrary ROI for calculating flow within these regions, but it averages the good flow with the bad flow, so you don't really know what the actual distribution is. Even the 17-segment model, look at each segment. Here's high flow, low flow from different arteries, high flow, low flow from all different arteries. Most of these regions are a mix of different arteries with different severity that then preclude precisely measuring the real defect, as you show here. Coronary flow capacity per regional pixel provides precise definition of each actual arterial abnormality. Here, for example, the ramus intermedius, comprising 25% of the LV with stress of 1.5 and CFR 1.6 in this specific region, outlined by the white lines, that because of the pixel distribution, we can do very precisely here, involving 25% of the subendocardium, not severe, actually could be managed medically, but quite precise based on the pixel distribution of the quantitation. Now, why CFC? From another point of view, it's called heterogeneity. Look at the rest flow is very high, the stress flow is very high, so coronary flow reserve is somewhat low. But when you put them all together, the coronary flow capacity map accounts for all this, and it's normal, high flow capacity. Now here's a different patient with low rest flow, low stress flow, like being on a beta blocker, but the increase in flow, the CFR, is quite good, as is the CFC map. But if one chose to measure only stress flow or only CFR, one would be grossly misled as to what's going on without looking at the integrated data. It's even more important that heterogeneity can occur regionally. We know that because of endothelial dysfunction, the resting flow may be very heterogeneous, here low, here high. Now take this little bit lower rest flow with a uniform stress, produces a nice high CFR. Now here's a high rest flow because of heterogeneity, normal resting reproducible heterogeneity with the uniform stress flow produces a lower CFR. It looks like there's a regional defect, a regional stenosis flow limiting, but there's not. It's due to heterogeneity. And when you account for all that in the CFC map, it shows mild diffuse disease in this infralateral distribution tapering toward the tip, but not the severe apparent abnormality seen on the CFR alone. Now, why coronary flow capacity? From another point of view, risk. So this is death, MI, and stroke or MACE over 10 years for each size and severity shown on the horizontal axis. So this is MACE as percent of the group, percent MACE in each of these size groups. So as we see for stress flow that's fairly severe, less than 1 cc per minute per gram, of this different part size of the ventricle, the risk goes up quite steeply, it's quite high. Coronary flow reserve that's quite severe, 1 to 1.5, also has high risk, increasing with size. But the risk of both of these measurements together as CFC predicts a much higher risk, 30 to 40% higher, indicating that there's independent risk that are additive from these, and the CFC captures that. So the best predictor of risk, and consequently, as I show you, of the outcomes, is a CFC, coronary flow capacity. Now, why subendocardial or non-transmural border zones? Why do we care? We have CFC, but is there something in addition? So here's an experimental model from many years ago, actually 1978, with a very precise 63% diameter stenosis, hyperemic blood flow, causes a pressure fall, and low subendocardial perfusion for this particular stenosis here, shown post-mortem because there was no PET scans back then. So I put this post-mortem section on the gamma camera, and you can see that the subendocardium for this moderate stenosis during hyperemia shells out. And if you do an activity profile, a good profile in the normal area, the subendocardium shells out and even epicardium is lost. So this subendocardial data is also very important as an integrated measure of the whole physiologic problem. And how is that related to pressure? This is a good study from Hoffman and Buckberg from not too long ago, showing subendocardial and subepicardial flow here versus intracoronary pressure here. And as pressure falls, the subepicardial flow is maintained, but subendocardial flow falls, And that fall comes at a mean pressure of about 34 millimeters of mercury, pretty low. You have to have a pretty low pressure. But when you get there, it does fall. But remember, with tachycardia, the perfusion to the subendocardium is very slow to recover. So the additional problem here is transmural distribution of coronary blood flow during reactive hyperemia after transient occlusion and experimental preparation with no stenosis. So this is coronary blood flow expressed as a percent of maximum. This is time, seconds after this 90-second occlusion. You have tremendous hyperemia. But look, the subepicardial hyperemia is very quick. But the subendocardial hyperemia is delayed by 20 seconds. And there's no stenosis. This is a normal heart. Now, if you have a stenosis, this subendocardial reperfusion after each systolic contraction that stops blood flow, this endocardial recurrent of flow is quite delayed. So how do we really measure this subendocardial perfusion? And why do we do it? Okay, on the relative tomograms that we see here of myocardial perfusion, there's 64 radii from the center of the LV that track the rest endocardial borders that are then superimposed on the stress for each of 21 slices. And for 184 PETs from healthy young volunteers, we have 180,000 radii that give us a normal reference and mean standard deviation of the subendocardial stress-rest ratio normally is 1. You take off 2 standard deviations and you get a threshold of 0.8 that is always abnormal. So any percent of the LV with a subendocardial stress-rest ratio less than 0.8 is abnormal and quantified as a percent of LV. So here's how it is. Here's one radius profile, this one, and we plot the activity. And so the endocardial stress-rest ratio is this area in stress divided by the rest. And so you get this ratio that in this case is less than 0.8 for 55% of the ventricle. Now we can also get stress endo-epi ratio. It's also reduced, but the primary power is in this one called stress-rest ratio. This ratio to this ratio is quite powerful. And here's a picture of it. You can see that during stress, the subendocardium is globally shelled out. And actually, there's decrease in the mean transmural flow because you're losing a little bit of epicardium too, but the greatest ischemia is in the subendocardium, as has been shown experimentally. So now let's go through some cases of each of these major themes and show you how they interact and what the outcomes are. So here's a case with LAD stenosis plus diffuse disease with a severe apical defect. It's not very big, but there. But then has non-transmural and subendocardial borders. There's the border that's green, moderate, then there's a subendocardial border. And here are the tomograms showing it shelling out with a decrease in mean transmural and certainly severe subendocardial ischemia. And this is the plot that incorporates the subendocardial abnormalities into the CSC map. So now you have 13% severe, 12% moderate, and a 33% subendocardial border zone ischemia. So the total risk area is 58% of the heart in the proximal LAD distribution, even though the severe part is only 13% at the apex. This shows you that there's a large border zone that defines the zone at risk around the severe defect that is highly predictive of high mortality. Now, here's a different case. Look at the rest images, and the stress images are relatively normal. And even the CFC map shows only a mean transmural stress flow of 1.7, not bad, pretty good actually, and a coronary flow reserve of 2, not severe. And yet this patient had severe angina and 3 millimeters of ST. How is that possible? What are we missing? And the answer is in the tomographs. that shows when you extract the rest endo to the stress endo, you have shelled out a severe area of severe subendocardial ischemia due to diffuse coronary artery disease. And in fact, here the subendocardium is half of the mean flow. So the actual subendocardial flow is down around 0.8 and 0.1, quite severe. So that it's important to look not only at the mean average transmural flow per pixel, region distributed, but also the subendocardium. And this is actually not uncommon. One would have a normal angiogram, normal stress images, bad angina during diaphragmal stress. And so why is this? We have to explain it. And the answer is in the subendocardial images. Now, on the other hand, this is a patient with normal images, the same level or a little bit less of diffuse CFC, CFR, and stress flow with no angina. What's the difference? Here, there is no subendocardial shell out because the flow has been restricted sufficiently by diffuse small vessel disease that the flow can't be high enough to generate the pressure gradient that compromises subendocardial flow. So this pattern of low flow with no subendocardial ischemia is typical of microvascular disease that's actually not commonly associated. You seldom see angina with it. Usually the angina is associated with diffuse epicardial disease and endocardial shell out, whereas microvascular disease shows uniform across the wall. Now then, it can be extremely and surprising. Here's totally normal images and very high flows, like a normal CFC map, and the diaphragmal stress is 2.9, very high flow. The coronary flow reserve is a little bit reduced because rest flow is so high. But look at the stress flow. There's no regional defect. It's very high flow, tremendous microvascular function, and yet had severe angina with ST change. Why is it? Because he shelled out the subendocardium due to diffuse epicardial disease, but very good microvascular reactions that produces very high flow and diffuse disease, drops the pressure, and causes subendocardial ischemia. And we see this in a small percent, but real, of people with angina, very high flows, but they shell out the subendocardium that normal imaging or the angiogram can't see. So now this summarizes the 4 types of transmural perfusion to put it in perspective. So here's a severe proximal stenosis, obviously LAD. He really loses the wall. It's pretty big. 54% of the LV has angina and very high risk. Now here's moderate stenosis plus diffuse disease, like I showed you before, also has angina, but a small severe defect at the apex. But it adds up to 58% of the LV because of the border zones and very high risk. Now then we get to the patient with diffuse epicardial disease. It's non-obstructive. He shells out the subendocardium, has angina, but when we look at a large number of this in a great large cohort, the mortality is fairly low, and there's no revascularization benefit on survival. And you don't know really, there's nothing to stent because it's diffuse, even though you know there's ischemia. So it's medical management. And then the final example is the microvascular dysfunction that we've identified as quite precisely separates out diffuse epicardial disease from microvascular disease, where the flow is uniformly reduced across the wall. There's no subendocardial underperfusion, and they typically don't have angina. The idea that's called microvascular angina is really a misnomer, as we published in JACC not too long ago. And it's because there's no subendocardial ischemia because of flow restrictions due to microvascular disease. Now, why CFC? Consider the risks and benefits. In a large series that we've published in the Journal of Nuclear Medicine, if you have big blue or little blue with a big border zone, your death rate in 10 years is very high. And if you have revascularization, it reduces it by 54%. Now, this is based on a revascularization procedure within 90 days after the PET to be sure that it was the PET that influenced that particular revascularization. With that same criteria, if you don't have any blue, your risk is quite low and there's no benefit from revascularization. Now, the question is, what happens to people that have blue that have a delayed revascularization after 90 days? Later, in other words, more of a natural history of what happens. And this is a somewhat shocking but fascinating story. Here now, this is mortality after PET, with or without revascularization, at any time after the PET. It may be longer than 90 days, it may be a year. And so this is death for each size and severity of the CFC map looking blue. And you see that the death rate is extremely high. And even if you have a delayed revascularization after 90 days, it drops the death rate by 69%. It's quite significant. Now, it is unadjusted for covariates and mortality bias because there's no ready statistical way of doing Cox regression or Kaplan-Meier where you account for size as well as severity and the multivariables that go along with every patient. But this is at least raw data that gives us some thought. Now then, if you don't have blue, but you got a little bit of moderate defect or good flow, the risk is very low and there's no benefit in revascularization. Now, this is a very important paper just published in JACC. In the European Heart Journal, also a version of it in JACC. And it shows death for global myocardial perfusion reserve, not regional, global. But it's a very powerful paper for the following reason. Even though it doesn't account for regional disease, it shows that when you have low CFR, actually you have reduced mortality in a non-randomized cohort. What's fascinating is that the separation of the groups by the standard deviation occurs at a CFR of 1.3, which is the regional threshold for a problem with CFR that we have in the CFC threshold. So it matches. But it has something very much more important. Since they had 3 times the number of cases as the one I showed you before in ours, you can pick up the fact that if you do a procedure, revascularization procedure, for a coronary flow reserve that's pretty good, you increase mortality, and that increased mortality is highly significant. That's a very important piece of information. So while it's important, the global CFR fails to differentiate from diffuse disease from stenosis, which you need to tell an interventionalist what to do. You fail to quantify the size and severity of artery-specific stenoses. And in this study, the quantitative data was withheld from the revascularization decision, so you can't really say it's a guide to tell you what to do with revascularization. Those are problems, but this is a powerful paper showing that if you do an unnecessary procedure, you actually increase the mortality, and if you get below the threshold, you're going to benefit. And with our pixel data, you can do that with a much smaller group and be fairly specific for individuals. Now, this is the next somewhat surprising, if not shocking, bit of data from a very large series where we have here the percent of patients with angina or ST and each size of severity abnormality on the LV for the subendocardial data and for the CFC data. Now then, it's a large series where of the total number, 20% had severely reduced CFC like this, 13% had moderate like green, and 66% had reduced subendocardial perfusion, maybe not quite as severe as this, but nonetheless measurable outside of normal. And of the whole group, 86% had calcium. So this is a high prevalence group. What's the shocking part? Of those patients with severe disease, only 42% had angina during diaphragmal stress or clinical angina. And the bigger the defect, the more angina you get. But even up here, at a quarter of the heart turning blue during diaphragmal stress, 30% had no angina. If you have more moderate disease, only 13% had angina. Of those with measurable subendocardial underperfusion, outside 2 standard deviations of normals, only 6% had angina, which means that we've identified widely prevalent coronary disease that we know exists from IVA studies, but we've measured it systematically as relative subendocardial perfusion that does not produce angina. Oh, this particular case did, as I showed you before. So the question arises, what causes angina? But we also know that those without angina have extremely high risk. So there's a substantial population with no angina that has high-risk disease that may not be getting revascularization because they don't have adequate symptoms. Now then, what else does PET tell us? This is an angiogram for the patient with angina, and there's no stenosis. So he gets a PET scan to figure it out, and lo and behold, he has a big diagonal defect. So we tell the cardiologist that, and he knows that, goes back, finds collaterals, does a retrograde PCI, and there's the open diagonal that was a previous flush occlusion, not seen on the angiogram that PET identified precisely. Here's another example, no stenosis angiogram. In this case, a ramus intermedius has a flush occlusion. So we tell the invasivist, he goes backwards through the collaterals and opens up, and there's the open ramus. Occluded vessels, flush, or stent occluded vessels and stents that bridge branches is very common now and associated with ongoing angina despite a successful procedure. And PET is the only way of finding it and discovering what to do. Now, finally, what about viability? It's pretty straightforward. You know about it, but let me show you the pictures. Large defect at rest, large defect at stress, great uptake with FDG. And so we get an automated ratio that calculates the hibernating myocardium, but importantly, also the partially viable non-transmural scar, partially viable. So there's a subendocardial scar that's viable, but it's viable not as hibernating myocardium, but as a fixed subendocardial scar, but with the subepicardium viable, that also needs to be revascularized when there's hibernating myocardium. And this separation of what's hibernating and what's partially viable non-transmural scar is a very important part of PET. That's a part of the software that's become very important, particularly for complex post-procedure problems. So in summary, PET and the CFC is an optimal gatekeeper for invasive procedures versus medical treatment only. It is routinely done here and is the standard for CAD severity to guide revascularization procedures that reduces MI or death while eliminating unnecessary procedures. Just to comment on this last comment, when I send somebody to the PET cath lab with this picture, 80% have a revascularization procedure. There are no false positives. The ones that don't get procedure usually have diffuse disease, suboptimal anatomy, and can't be done. So there are just simply no effectively essential false positives, and false negatives are really quite uncommon because we're pretty compulsive. We see a lot of disease. As I showed you, we can pick up 60% of patients in this whole cohort that have mild subendocardial underperfusion, so that we're seeing what's there. We're seeing the real disease, and we're seeing what needs fixing and what needs medical management. So in the end, myocardial perfusion is the optimal personalized coronary care. And it is mainstream. It's not just me from 50 years ago. It's in major cardiac tests, the basic physiology that somehow is forgotten. Like the call for microvascular angina comes from a group that has not remembered that subendocardial perfusion was actually observed before PET existed, before FFR. There's a lot of data that we need to incorporate now through PET imaging into the clinical circumstances for positron emission to guide coronary heart disease. Because quantitative myocardial imaging is the basis of personalized care in an individual, including those with a normal angiogram where they may have diffuse disease or microvascular disease. So thank you for listening. It's been a pleasure. And I hope that you can consider myocardial perfusion as an important part of the way you look at heart disease and a better way to fix it. Thanks very much for your attention and best wishes. Now then, I have several questions. So what is your take on the ischemia trial? That's a great question. And in fact, we're just publishing an analysis with a suggestion of why that's the case. The ischemia trial showed no benefit for revascularization procedures in patients selected by either a 50% stenosis or an FFR or an angiogram. Let's see, it was 50% or abnormal SPECT. And so it didn't show much benefit, and there was a problem with recruitment and a change in the endpoints. It's a good study because in a way it tells us something, that if you don't have severe disease, you don't need the procedures. And so my view of ischemia is that all three of the technologies used, 50% stenosis, we know is completely inadequate for telling you how bad the disease is. We know that SPECT imaging is helpful, but it's not quantitative. I've showed you images that had fairly severe disease that you could only identify quantitatively. And certainly the FFR is a good step, but it wasn't done in everyone. And we also know that the FFR trials have not shown a reduction in mortality. So the problem with the ischemia trial is the selection of the patients. They were selected not for severe disease by quantitative methods. And therefore, it's an important part of our knowledge, but has to be viewed in terms of this kind of new knowledge where we actually quantify. Now then, that means that we should do a trial of patients that look like this. That's a problem. Our CPHS committee, and no cardiologist that I know of, would randomize this patient to revascularization trial. It might be feasible. It probably needs to be done. But remember, it is also a problem of recruiting patients who might not be willing to take the chance when they got a 30% chance of dying in 5 years that's reduced in non-randomized trials. So it is a true scientific dilemma that needs to be addressed. My sense is like gravity. If you know the rules of gravity, Einstein and Newton didn't need to jump off a cliff to prove gravity. So if you make precise enough measurements in a large database and follow those patients, you may be able to get a pretty strong clue as to who needs revascularization without an ideal randomized trial, which I would greatly support, but I'm just outlining the problems of doing it that in fact ischemia demonstrates. Okay, that's the best I can do to a superb question. Now there was another question. In the images you showed the subendocardial schemes to be accurately reflected by TID. Is that usually the case? Also a superb question. TID is a complicated term, transient ischemic dilatation. It clearly occurs in cases where the EF falls and you've got a big problem. But there also is good literature measuring EF by echo during the imaging with SPECT, and the TID that observed is not associated with fall in the EF. In fact, the EF might be enhanced on the echo with hypercontraction. So there's a part of TID that represents transient ischemic dilatation. There's another part of DID that has nothing to do with LV function, but has to do with shelling out of the subendocardium. And when we look at it with PET, the majority of cases of TID, because we measure TID with PET too, the majority of cases of TID with PET is due to subendocardial shell out, and the EF is normal. So I think that the use of TID as an independent measure of what's happening is complicated by these two physiologic observations. And in the end, you can only tell which one it is by actually having quantitative imaging where you measure the epicardium, the endocardium, the EF, and you look at the shell out. And I think that's going to be a very important part of our future evolution in cardiology, because realize, like I was showing diffuse atherosclerosis in many people, PET will see subendocardial underperfusion in many people. So you say, was it too sensitive? Well, that could be. That's a clinical judgment we make. But what PET is telling us is what's the truth. What is nature doing with our hearts? And then we have to decide. But in most cases, with only 6% of these people having angina, this is simply like IVUS. It reflects what's there that needs generally medical treatment. So again, superb questions. Thank you. Next question, can you comment on the clinical utility and difference between stress endo-epi versus endo-stress epi ratio? That's very smart. You're really paying attention. We're wrestling with that. And the answer is, statistically speaking, the stress endo-epi ratio, let me get back to it here if I can. This one, the endo alone, endo stress rest ratio, is statistically the most predictive of angina, or while it's not high outcome, of whatever does happen. Whereas the epi-endo ratio during stress is a little bit, is also, we can measure it outside of normal limits. But if we're using it to predict angina, it's not nearly powerful as this. And there may be a reason. And the reason relates to the prior question. When there is a subendo change, what happens physiologically and technically? There are two different things. One is you actually shell out, but remember, in the epicardium that's left, the hottest point is moved out from a purely technical imaging point of view because the highest activity has moved out. So it appears as if the LV is dilating when you're just simply moving it out, but it is probably dilating a little bit. So that change can somehow introduce a little noise into the endo-epi ratio in stress alone. But when you look at the endo alone stress rest change, it seems to be a pure signal. But we're exploring that actually right now in a large series statistically in order to do a very sophisticated analysis of which one predicts angina best. But a superb question that needs a research answer. So next question is, interpreting nuances of CFC and MFR is difficult. How can we reassure new uses of CFC that training will occur as per your guidelines? I think all technology is complicated. Back before Koch and the microscope, people thought disease was caused by bad air and miasma. Then when he came along and says with the microscope, well, there are bugs in there. People thought, well, I don't believe in bugs. I don't have a microscope. That's crazy. So every time there's a technological advance with the aim of discovering the truth, a new tool, PET in a way is a new microscope of a kind. We see things that we usually can figure out and understand and then translate into clinical medicine. So the fact is that the software that we have presents all the data. It presents the relative images. It presents the subendocardium. It presents the CFR and the stress flow and the CFC map so that everyone can look at what they're prone to believe in from their past experience. And so we slowly advance this by everyone better understanding of what's happening. And I think that new technology is always difficult, but when it's presented not from a commercial point of view, from the view of a scientist trying to discover what's the truth. What's the truth about this heart? What's the truth about my heart? That's what I spent my life doing. I receive no commercial money. I don't get anything out of the software. This is purely a search for the truth. And I think that I've showed you the data the best I can. And the Society for Nuclear Medicine and the invasive cardiologists that here really love this stuff. They trust it. They make decisions based on this. It will slowly evolve, but it's going to take an open mind that's not contaminated by too much commercial hype for somebody else's. If somebody else has got something that works as well, that's great for me. Doesn't matter. MRI can do this, but it's really tough to make the measurements. But to pick one measurement, CFR, or stress flow, or global, you have to understand that nature doesn't care about what we think. If you choose the wrong one, you'll be wrong half the time. We need to discover nature's truth and then move it on as we learn into clinical medicine. Thanks for the question. Okay, next question. Can you expand on viability non-transmural versus hibernating? Why important revascularize both? Fair enough. Let me get to that one. So what we discovered was when we do the cross sections, we find that there are some sections, here are not too small, it's a border zone that you might expect. Some sections have enough flow in the epicardium that it doesn't need FDG uptake. Yet right next to it, there is FDG uptake. So in looking at the cross sections and looking at the flow ratios, the FDG flow ratios, we realized that some parts of the myocardium then are viable because they have more FDG than flow. And other parts, they're clearly viable. They take up rubidium. They may or may not take up FDG because there's enough flow in the epicardium that it's no longer switched over to anaerobic metabolism. So clearly there are border zones of viable epicardium and then transmural hibernating. So the issue is, what do you do about it? Well, in this case, it's mostly LAD, you need to fix it. But now, what if it were, and we see this, I'll give you a different example. What if it were half this region were viable epicardium, but then the other half was hibernating? If you lose the artery, you could also lose the remaining subepicardial viability, even though the subendocardium is a scar. So we've wrestled with it and realized that when you have viable muscle, either transmural hibernating or viable subepicardium with a subendocardial scar beyond a flow-limiting stenosis, it's best and the patients do better if you revascularize everything. Now, in this case, part of it is in the circumflex distribution. So in this case, fix the LAD. If you did bypass, you'd fix the circumflex, but the flow's not so bad. There's a subepicardial border zone scar, which you'd kind of expect. So in this case, the hibernating drives you to the LAD. But if this were somewhat involved in the LAD distribution, you want to fix it too. So it's again complicated for each individual patient. It depends on how big the subepicardial viability is, its distribution in relation to the hibernating. And it's this sophisticated difference that is important for how you revascularize. Do you need to go to bypass, or can you do a stent in one place or two maybe? So this also needs to be examined in more detail because it's an advance over the old concept of FDG mismatch. It's a quantitative advance. And like all quantitative data done properly, it tells you more than you might have realized with just a visual impression. Thanks very much. A great question. Now, the next question was, are the vascular overlap on your map specific for coronary vascular? What about non-standard vasculature? Oh, that's a great point. I put on here generic maps, but actually the images themselves are highly specific only for the artery distribution as it actually is. And here's the example. I've drawn in a generic LAD, circumflex and right. That's the orient people. That has actually nothing to do with the data. This is the actual data that tracks the actual artery. Now, when people learn about this, it would be obviously acceptable, if not preferable, to remove these generic markers and then read the primary data. I put it in because most people don't really realize that this is what a ramus intermedius looks like. It starts anterior, wraps around the anterolateral wall, and typically goes to the lateral apex. That's a classic distribution of a big ramus intermedius. So again, you're quite correct. These generic overlays are simply to orient somebody, but remember the data itself is specific for arterial distribution, as I showed in this example. Great question. I'm glad you clarified that. Thank you. Okay, you'll have great questions. You all are a wonderful audience. I appreciate the opportunity to show you a passion that's been mine for the last 50 years. I hope you all see the power in this for understanding how nature really is, how our arteries are, and how you can optimally care for people with heart disease. It's an honor to be here. Thanks very much, and I look forward to the future with you. Thank you.